Hello and welcome to the Center for Healthcare Health Design's Evidence-Based Design Journal Club. Thank you for joining us. I'm Dave Sine, your host for today's session. And as a bit of an introduction, I'm the Chief Risk Officer at the Office of Quality, Safety, and Value at the Veterans Health Administration. I'm probably better known as one of the two co-editors of the National Association of Psychiatric Health Systems Behavioral Health Design Guide. The purpose of the Evidence-Based Design, or EDB, Journal Club is to broaden the design community's knowledge, understanding, and application of built environment research. Continuing education units are available for this webinar from the AIA and from EDAC. To receive credit for your participation, you can download the forms at any time by clicking on the Show My Media Library icon, which is located on the top toolbar where the red arrow is now pointing. You'll have access to the AIA quiz, the EDAC form, and today's presentation slides. To download a file, click the green arrow next to the file. When you're finished, click the double right arrow at the top left corner of the media library. The library will close and the slides will refill the empty space. For EDAC credit, complete the verification form and retain it for your records. You'll need to submit the form to Castle Worldwide at the time of your renewal. For AIA credit, complete the verification quiz, purchase a CEU management fee for $10 from the CHD store, and submit the verification form to Shannon Rockline. She'll upload the credits to your AIA account, and you'll find Shannon's email address included on the form. I'd like to take a moment to review how to use the chat feature so you can ask questions or submit comments on what you'll hear today. As shown on the slide, just type into the chat box where the red arrow is now pointing. Please be sure to chat your questions to all so that all attendees on today's call are able to see your message. If you're having any technical difficulties, please type your issue to moderator in this private conversation, and we will see how we can help you. I'd like to now introduce you to the lead author of the article we are discussing today, Mardell Shepley. Dr. Shepley is professor and director of the Center for Health Systems and Design at Texas A&M University. A registered architect with 25 years of experience in professional practice, she has conducted research and published extensively on the topics of post-occupancy evaluation, pediatric facilities, behavioral health, sustainability, and health facility design. Her books include Healthcare Environments for Children and Their Families, Design for Critical Care, Health Facility Evaluation for Design Practitioners, and Design for Pediatric and Neonatal Critical Care. Thank you, Mardell, for joining us today.
Thank you for this opportunity.
As I mentioned, we are hosting this event to identify the everyday practical applications of research findings in a published article. Today's featured paper is Design, Research, and Behavioral Health Facilities, written by Mardell Shepley and Samira Pasha. On today's call, we will have an active discussion about different key factors in your study. We ask our audience to pose questions throughout the call today, and we will take time to answer them at the end. So please, everyone, be sure to join in today's discussion by chatting in your questions or comments as they come to you.
Well, I'd like to begin by talking about some of the concepts behind this project. And just before I do that, I'd like to acknowledge the participation of the various task force and task force leaders who helped this come to pass. So you can see their information on the cover of the article, and really would not have been possible without support of at least a dozen people. It was a big task taking this on. So what are the key concepts that we were looking at? Well, we know that evidence-based design has generally been a topic of interest to architects in the last, say, 10, 20 years, to environmental psychologists probably since the early 1960s. The issue that we recognize, though, is that there's very little out there on behavioral health facilities. And this is the case in spite of the fact that legislature has been in place that indicates that it is our responsibility to be providing the best possible environments for these individuals.
Mardell, that's kind of surprising given the driver you just discussed. Why isn't there more research done on behavioral health facilities?
Well, I pull up a few topics out of the paper itself, and it has to do with people and place in part, but one of the things would be is that there's so many different diagnoses under the category of behavioral health, ranging from drug rehabilitation to even autism are more standard diagnoses, depression, eating disorders, that it's difficult to come up with a one-size-fits-all solution. The other thing is, in parallel to all these diagnoses, there are multiple kinds of facilities. So those facilities need to be addressed. Inpatient versus outpatient has dramatically different needs in different populations. The other thing is, when you're trying to gather data with people in behavioral health settings, we acknowledge from the get-go that these individuals are facing certain challenges that might inhibit our ability to gather information or obtain permission to gather information. And there are a series of things such as lack of funds, et cetera, that also get in the way, and we'll talk about those later.
I'm looking at the objective slide now. What made you want to take on this project initially?
Well, it came to me by accident many years ago, an opportunity to work on a children's psychiatric facility. And during the programming process, we found that they actually gathered data about where children got in trouble and what the trouble was that they got into. So it was a perfect living lab to look at the impact of the environment, looking pre and post. So this was many years ago, and at that time I did as much of a literature review as I could and realized there's just really nothing out there on this topic, which was all the more reason to conduct a study. So with time, life tends to circle itself back around again. A lot of issues such as post-traumatic stress syndrome, et cetera, have received a lot of attention lately, and there's renewed interest in behavioral health. So I thought, okay, let's go back and look and see what's done. And a couple of firms had contacted me in advance asking questions about this. So we decided, okay, we're going to assess this to the best of our ability.
And the historical perspective is important, but why tie to inpatient only?
In fact, the journal does not focus on inpatient purposefully. Most of the work comes out of that setting, and I'm thinking that researchers do that because of the nature of the population being somewhat more vulnerable than people who might be in an outpatient setting, but also they are within those environments over a period of time. So it's not like someone's coming in on an outpatient basis and then leaving again. So you have an environment that's very specific over a period, as opposed to someone who's going to be in there for an hour or so. So there are a variety. All these, the needs are broad, and inpatient just turns out to be one of those topics studied most frequently.
I understand. And tell me about the tie to the guidelines. Why tie to guidelines?
Well, our perspective from the beginning is that research isolated makes no progress in terms of addressing the human condition. So one tool we have for taking research and trying to implement it is to incorporate it into guidelines. And so the notion behind the article, behind the paper, was essentially to help people take the next step forward. What is the relationship between the research and the guidelines, which turns out is very minimal? And if we wanted to amplify our efforts, where are the funds to make this happen? So the very purpose of this article is to enable people who are in practice and people who are conducting research to mobilize around the topic.
So I'm on the methods and overview slide. Could you tell me a little bit about the methods?
Sure. We looked at, as you see here, more than 300 articles. When you do a search, you actually probably cruise through. If you come up to 300, you probably looked at 1,000 before you got that far. But 300 of them were sufficient to incite our interest and see whether they were going to be appropriate for this application. And you see these 4 topics in blue across the top. Basically, they need to be related to behavioral health. But we were also looking at, as I said, guidelines and funding articles that address that. We tried to focus on post-1960. Not that the nature, most human behavioral health issues have been with us for centuries and centuries. But post-1960, the way people gather information is similar enough so that we can compare it to what we're doing now. And then lastly, we wanted, as best possible, to have these articles originate from peer-reviewed journals. So someone besides ourselves who are experts thought they were worth sharing with the rest of the world.
Well, they're a good approach. Did you fully review all 115 papers, or were some of those less relevant when you started getting into further screening?
We actually reviewed all of those, and I think they're probably included in the reference list. Some of them received more attention than others. Some might just have a little parenthetical citation, but we were trying to get as much out on the table as possible in case someone was trying to do follow-up research.
Well, did you see any notable differences in either quality or topic between the longitudinal studies and those that were more cross-functional?
I would say that there are not enough longitudinal studies to make a statement like that. We found frequent contradictions all around, and I think those are likely attributed to confounding variables that might have been influencing the outcomes of the study. So not enough. I wish we had so many longitudinal studies that we would be able to make that kind of assessment.
Interesting. You know, the overall tone of your paper is that more research with better methods is needed. But are the studies you examined still generalizable or generalizable enough to be useful to behavioral health designers and other researchers?
Well, we talked about this in several group meetings, not just with the authors, but with the Center for Health Design. And in a sense, we have to start somewhere. So to say that they're generalizable from an inferential statistical perspective, very few could be generalized to other settings. However, by calling attention to these, it helps other researchers who might want to address this problem. They get a sense of what that body of research is and how they might reinforce a particular conclusion that might have come up. The other thing is, practitioners were out there, we're trying to make decisions as quickly as possible, and it's probably better to have some information than none at all. And one of the benefits of somebody saying, okay, I read that this is probably the case, I think I'm going to use it in this facility, we have no better information, that facility then becomes a laboratory for future research. So they've tried it, and did it actually result in the same outcome? So sharing this information, there really is no downside to it, unless people just say, well, I read this here, and this is fact. There are very few facts out there, even when you have studies that have been replicated many, many times. Truth is elusive, so that's still something that's up for grabs.
So would you consider this to be a broad exploration of the various groups and organizations looking at behavioral health design?
I think it is pretty broad. We might be missing. We looked at articles published in all the Romance languages. We also had access to articles from China and Korea. We didn't cover every setting, and if people have done studies and not published, then we didn't have access to those. So I think it is. I feel confident that we did the best job possible based on our current excellent database search systems.
The other thing I was struck by is that there's so little funding available. Why do you think that is?
Well, this is all conjecture. I like to sort of invent the world as I might think it's going to be. And one of the things is behavioral health is still a topic that has a certain amount of stigma associated with it, and people normally are more inclined to embrace something that can be measured in more physical terms. But in my opinion, the barrier, the boundary between physical health and mental health is non-existent, because if someone is suffering from a physical problem, then it has manifestations in potentially depression or stress. If someone is highly stressed, they might develop physical characteristics and associated with that stress. So they are. It's just a question of the society shifting a little bit, so we accept mental health as one of the issues we have to address. And as you know, in the United States, it's coming up more and more as an important topic, and higher incidence of people. They're recording higher incidence of people with mental health issues than they ever have previously.
Why do you think it's important to come up with a system for defining terms as you did here?
Well, it's a question of being able to communicate, and we know even in the field of design, we have a whole jargon that we use, and we sit down with a client. Most of us put ourselves in check and try not to speak architectese. We are looking for a common language to discuss what the issues are. So if we want to, maybe we need to think about what the various topics are for facilities. Here we list 3, but there are subsets within these. And when you're talking about behavioral health, the age of the population, or even potentially the race and ethnicity, may have an impact on what's going on. So you determine what the demographic features are that you need to be talking about. And when we talk about age group, we should have a common idea about what that age group is. And then there's a whole series of potential programs that we could be addressing. So just trying to see what those categories are. This framework actually helps people develop a grounded theory about how to approach research in behavioral health, because they might include these topics as subsets within this grounded theory, and we might speak about that later.
Tell me a little more about why it was important to define this by program as well.
Why is it important to define by program? Because as I started out, the people who are suffering from post-traumatic stress syndrome are going to have very different needs from someone who might be dealing with an eating disorder. There are overlaps in all of these things, and one thing may relate to the other. Our substance abuse facility may have different goals, outcomes that they're seeking than someone who is working with gerontological psychology. So there's a whole lot of different approaches people might have based on the program.
How did you define a research tool?
Well, we could have limited our paper just to the studies, but if there are people seeking tools, and I'm talking about architects with research components or academics, if they are wanting to undergo research and they're seeking tools, it's great to have one location where you can see what most people have used to date. So they can take these particular tools and apply them to their own studies. There's 2 benefits to that. One, you don't reinvent the tool, which in and of itself can be a whole dissertation. And the other piece of that is you can take the results of your study and compare them to predecessor studies. So we tried to come up with what the tools are that are available, and then we encourage people to look at those rather than reinventing the wheel.
You previously mentioned that one of the challenges is not finding enough longitudinal studies. What were some of the other challenges in this project?
Trying to make sure that people were considering what the confounding variables might be, and that means identifying things that might have been external, such as changes in program protocols, et cetera. Other challenges were that we don't have that many venues in which to publish papers on this topic. There are a few, like HERD and others, but generally what we do tends to fall between the lay press, lay publications, professional publications, and very sophisticated academic publications. Our research is all about application, and so meeting the requirements at both ends of that spectrum limit the number of places people can put their work out there. That's changing a little bit. That's been the issue.
Well, I suppose some could look at some of the included studies in your paper and ask, why bother include that particular study? How would you respond to that?
Well, again, if someone looks at that study and feels that it has a shortcoming, take that study and fix it and see whether you're able to come up with the same results or just structure a better research project. So this is all about laying the foundation. This isn't about solving the world's problems. This gives people a foothold for being able to make progress.
Great answer. Did you find a balance between safety issues and those of a therapeutic or healing environment in your research?
So, again, I think these 2 things are integral. For example, someone might be concerned, in other words, if you're looking at a therapeutic environment, that therapeutic environment might reduce stress. If stress is reduced, then there might be less aggression. So it's really, again, hard to separate the two. In my opinion, a therapeutic environment is going to be a safer environment, and you can't use the sort of therapeutic environment to solve all the problems. But I think you wind up being tied and inhibited from making progress if the only changes you're making are things like putting covers over sprinkler heads. It has to be a whole package.
Have you seen, or could you perhaps recommend a change in the curriculum of healthcare architecture based on your findings, perhaps an elective on research or how to study a study?
Well, there are a couple of universities out there that are on top of this, and they're graduating as part of their certificate programs. They're being trained to have basic understanding of research. By that I mean they can read a research study and know what it means. I'm not saying that they're necessarily trained to go out and gather data, although some of them are. So this is where I sort of make my plea for the various interior design or architecture accrediting programs. We need to speak up and inform them of how critical it is that we be providing young designers with this information about how to interact with research. And so I hope everyone on the line, if you have an opportunity, please, and you share this objective with me, I hope you're going to jump in and let people know how important it is.
What can you tell me about this slide, environment and social behavior?
I put this up here because there's several categories of research that I discuss, but I put this one up here because the notion, this is one of the most highly debated topics in behavioral health, residential behavioral health facilities. And these are really, that's actually a great barometer. If you're saying, gee, I want to do a study on this topic, what you want to look for is where the controversy is, because that's where you're going to be able to make the best contribution. So the issue of whether we provide private rooms or shared rooms has been argued by various researchers. These particular researchers came forward saying they thought that the private room setting gave people a greater sense of control and actually might support the healing process. Although I have spoken with practitioners in behavioral health, and they say, they are afraid for individuals being left alone for fear that they'll have opportunity to do self-harm. So it is a pretty significant issue, and I don't think anyone's looking at ward design. In other words, more than 2 beds per room. But I think that overall, the debate is really about this private room versus this shared room, and people would be doing a great service to the field were they able to look into that a little bit more. And it might differ. If we're talking about adolescents, there might be a different conclusion than if we're talking about seniors or other populations. So put that out there again.
Interesting. I particularly like your discussion about furniture. What are your safety concerns for furnishings?
Well, I think that even back when I was working on the children's psychiatric facility, which is now probably 25 years ago, furniture manufacturers were aware of some of these issues. And the issues being you don't want to have furniture you can pick up and toss, or furniture that's easy to destroy or can be taken apart and used as a weapon, or used for the child can use it to hurt themselves. So that's one of the issues. I think some manufacturers have been very thoughtful about what this might be. But what this is showing right here is that many programs encourage social interaction among patients or among residents, and there are different ways to do that. And we talk about sociofugal versus sociopedal seating arrangements, one of which allows people to come together, sociopedal, and other ones which encourage people to not interact, sociofugal. And I always think of centrifuge as something that throws people apart, if you want to remember it that way. But if you look at these particular arrangements, the classroom, top, middle, that would be a sociofugal, and sociopedal would be more like the items you see on the bottom left and the center bottom image.
Is it true that some patients may have an extreme focus on self-harm, for example, suicidal ideation?
Oh, it's a huge issue. It's the one that troubles most people that are operating in these healthcare facilities. The possibility of ligature and self-harm is clearly something we have to confront in every facility that we work on. At the same time, as I mentioned, we're trying to create this balance between this very practical side of things and sort of the less tangible therapeutic environment side of things. And they're not in conflict with one another. You can really do both.
Well, given that lens of self-harm, isn't art inconsequential in that context? Aren't there bigger issues?
Well, that's pretty much what I was hoping to share, and that's that we are trying to protect people's lives as best possible. But in an abysmal environmental situation, you might be in a room where you can't bring any harm to yourself, but your condition could deteriorate even further if you don't have some other external support. So, and what we have not discussed yet is the role of the support staff, which is going to be, of course, the most critical thing in all of this. But this is a package. This is a bundle. None of these things should be looked at alone. As you say, we don't want people to get hurt, and we should be looking at that first, but we can't turn our back on these other items that have a role to play.
Well, do these issues then apply to non-behavioral health patients as well?
They do, and as I've advocated, I think that your needs with regard to dealing with standard illnesses and your needs with regard to things that might be more emotionally based, they're really one and the same, and they're on this continuum, this spectrum. So I think it's always interesting to look at Powell Lawton's environmental press theory, and that's LAWTON, environmental press theory, competence press theory. And he basically says we're consistently looking for a balance between the challenge of the environment and the capability of the individual. So the more challenging the environment, the more capable an individual should be, so that those two things come together in the middle. And that can work both ways, even in a psychiatric facility. If your environment is so dull and so uninspired, that has negative psychological effect in some ways as much as if it's overstimulating with too much going on. So you're looking for this balance, and because the population in a psychiatric facility might be diverse, you're also looking for the flexibility or presentation of options so that people can seek the environment that is most supportive of them at that point in time. That would apply to a hospital as well, a variety of choices. So if you find your way through and you're feeling pretty stable, you have one environment that can be relatively stimulating, but if you're feeling overwhelmed and you need to control what's going on, you need to be able to have access to privacy.
Are there special considerations for children and adolescents in this environment?
Well, I think so, and this is a study in 1995 that I was referring to with regard to adolescent facility. Children, it's the same thing that we have in the standard inpatient setting. A 3-year-old and a 16-year-old have dramatically different needs, and they're both different from what an adult would need. They're just not miniature adults, as we all like to say. So that sort of lends itself to the variety. What we tend to know is that very young children have higher needs for sort of a parental support or supervisory support, and as you get older, you have this need for independence, and you want to come together with adolescents, people of the same age. So there's this transition that goes on, which puts us back. If you're doing a facility for children, you need to be thinking, probably separating your children into groups by age, apart from potentially gender and level of aggression, and trying to provide the environment that's going to best suit that group.
One of the things that struck me in the conclusion section was why so little work in this area since the 70s?
Well, I think that you can link this back to a variety of things. One is social transitions, and in the 70s, in the late 60s and 70s, there was a pretty, as you know, in the United States in particular, a significant engagement with the people, so to speak. And the work of Henry Sanoff and a lot of other people involving communities and thinking about individual behavior, individual needs, but working for the masses. And then we sort of transitioned through another period where the emphasis has been placed elsewhere. I think the nature of programming, design programming, has changed in part because of this. The thing about research, as much as it appears to some people to be this sort of, white jacket, test tube kind of approach, what it really is it is a way to reach out to humanity and take care of, address what their needs are, thoroughly understand what their needs are, rather than trying to guess at them. So this is part of this pendulum I think the society has gone through socially. And then there's just some plain, there are trends in anything. People move in a certain direction, and then they sort of get a little burnt out, and they transition. They get picked up by some other idea, and that's the human nature to be making those transitions. But I think we're circling back to being more aware of the impact of mental health. So I think this is there may be in the next decade more studies that help answer some of the questions that we are asking.
Well, that's hopeful. On this slide, what did you mean by framework?
Well, the field is so complex. Or any single question you might ask about behavioral health has so many underlying complexities that where you really need to start is with an overall framework that places your study in the context of an overall push to explore needs. So there are a couple of individuals who have generated these theoretical frameworks. In a sense, they're philosophy. You might look at them as if it was a philosophy, but it might have what are the 4 or 5 multiple approaches we have towards supporting therapeutic environment, and maybe another one is about the safe environment. What do those relationship diagrams look like? And then as a researcher, you look at yourself in the context of that, and you say, well, I'm going to look at this one, and this feeds back into everything based on this overarching relationship. So one of the first things anyone who's doing a research project should do is place their efforts in the context of this framework. And coming from me, this is a cry in support of qualitative research, because most of these theories come from qualitative, grounded research approaches, where you are working in focus groups, doing interviews, observing behavior, and creating this, starting to understand what all of this means relative to what approach you might have for a particular project. And there are individuals who have proposals for looking at health broadly. So, and I mentioned a couple in the paper. Samara and I mentioned a couple in the paper that I suggest you take a look at.
The last one on this slide has to do with funding. Did you find any difference at all in the quality of the studies that can be determined by looking at the sources for the funding?
Funding was not typically provided, so we were not able to do that, although that's a good question.
Well, let's go into design trends, and before we start, just a reminder to our audience, if you've got questions, to type them into the chat box, and we'll get to those as soon as we can. And I'm looking at your third down from the top bullet here. How would, if the sense of control is desirable, how do you provide that sense of control for this patient population?
Well, sense of control can be accomplished typically by providing options. So thinking about control, it's one of the basic tenets of environmental psychology, choice and control. If individuals have choice, they feel they can have more control. When they have control, they tend to have their stress levels go down. And privacy, all privacy is control of access to oneself. That's why it becomes, people may or may not need to be private, but they need to have the option to do that. So this gets back to this notion, the next one down, which is environmental flexibility, that you provide multiple settings to allow people to seek the place they need to be based on their current condition or their condition at that time.
And you've got a bullet here about environments for drug and alcohol. Do they need to be substantially different from other environments?
They probably are going to have some differences, although many people who are dealing with drug and alcohol addiction have more complex behavioral health issues as well. So I've heard people say it's not quite as controlled an environment, but I think it would depend on the individual and their particular situation. So you might, even in that case, if you had a facility, it might have multiple units based on your assessment of the safety of that individual.
And within this context of design trends, disadvantages to private rooms?
Right. Well, the primary disadvantage is likely supervision. Some people feel that it will be too easy for someone as a second possibility. Some people think it would be too easy to separate yourself socially if you have this opportunity to access a private room. Then I've heard it argued that you can use various protocols to keep people from sort of escaping there unnecessarily. But I think the big issue we need to deal with is it as safe as a shared room?
Well, thanks for the clarification.
Yep.
In every study, there's always a section on limitations. Tell us about the limitations of this particular study.
Well, I know there's work going on out there that we're unaware of. I certainly hope if there's somebody listening now and you're aware of something that you would send it to me, and so we can include this in our library of potential articles. There may be things happening in countries that are not sharing it. One of the limitations sometimes is that firms are doing their own work, but they're keeping it in-house, and it doesn't get distributed to the outside world. And, of course, there's never enough time to – a great thing would have been to look at the individual guidelines and then try and align them with some of the studies that we came up with to see if we can start creating sort of an appendix that supports guidelines. This work is just in its beginning, and I hope other people, in its infancy, I hope other people take on some of these tasks.
Are there any issues, maybe perhaps ethics issues, we should be discussing regarding the use of proxies when evaluating patient perceptions? Well,
by proxies, meaning that if we ask the staff what we think a patient is or a resident might be feeling, there is sufficient literature out there to tell you that perceptions are often different. However, that may be the only information that you have, so I think it has some substance because of that. And I don't think I would consider it unethical. I just think the disclaimer has to be, well, we know certain studies say there's no relationship. However, these staff feel it's this way, and perhaps this is correct. Phase 2 of the study will be to somehow get the information from the patients or residents.
Well, we've got a few questions for you, Mardell. We have one from Heather Lewis, and she asks, in designing a child and adolescent unit, we have separated the developmentally delayed into a separate subunit. However, the clinicians are leaning towards keeping those children separate from each other, studying alone, eating at their own table. While the general population has more communal arrangements, given this population, is this appropriate?
Well, you know, I can't pretend to be an expert on children that are developmentally delayed or with any psychiatric condition of a child, although what I've been reading more recently has been integrating these populations has turned out to be beneficial not just to the child who's developmentally delayed, but also to the children who are associating with that individual. So that's just my opinion, but I don't consider myself an expert on that.
Well, thank you. We've got a second question here from Tahsin Hussein, and he says, hello. I think he may know you. I remember, because he says, I remember you talking about the children's psychiatric facility in my programming class at Texas A&M, and you had mentioned that the entrance to the facility had the most behavioral incidents, which I thought was very interesting. Could you just reiterate your findings to this audience?
Right. Hi, Tahsin, and she is, again, yes, indeed, she was a student here at Texas A&M. And thank you for asking. There were problems at the entrance, and there were problems in the corridor. One of the theories behind the paper was that if there were spaces that did not seem to have territorial assignment. In other words, this was a public space. Acting out behavior tended to increase. So our notion was that we needed to make sure that the transition between public and private and semi-public, public, semi-public, and private was clearly indicated, and that our hope was that if we eliminated these areas where it appeared to belong to no one and no one was supervising it, then there would be less aggression. So that was our hope. Well, we found out from the study we looked at a new and old facility and basically found that a lot of the number of incidents generally went down, but what did go down was the number of highly aggressive situations, and so there was some benefit to the change.
Well, here's a question I would have asked myself from Kelsey, who asked, following up on the lack of research since the 1970s, how has the improved diagnosis and identification of mental health conditions contributed to the ability to research these environments? Did you see a direct correlation with this?
So, improved diagnosis and identification of mental health conditions. We have not actually, to my knowledge, taken advantage of this sort of clarity that's coming around mental health issues. However, it gets back to this issue of coming up with a common language and communicating. I think this was a necessary step to enable us to move on. And as you mention it, I say to myself, well, maybe that's another reason why we've had trouble putting together behavioral health projects, because we have not, behavioral health research projects, because we have not had this kind of clarity. So it's a good question.
And we've got one more, and I encourage people to keep typing these in. They're flowing in now. Another one from Ellen, who said, I've heard there is sometimes pushback from owners to create a healing environment for fear of the safety issues, essentially creating a lockdown type of environment. You mentioned the link between therapeutic environments and reduced aggression leading to safety. Are there other suggestions you have on how to bridge some of these deep-set cultural issues within organizations?
You know, these are both cultural and economic considerations, because sometimes if you want to provide visual access to gardens throughout a facility, then you have to build those gardens and you have to maintain those gardens. So I think one tool that's helped convince the culture from an economic perspective has been our look towards return on investment and the business case for evidence-based design. So anyone who is actually thinking about conducting a study looking at therapeutic environments, allowing that to percolate down to looking at the costs associated with aggression, that is going to serve people better. Now, I'm not convinced that that a therapeutic environment, by that we might be talking about art or access to nature or something along those lines. I'm not convinced that in and of itself is going to create a safety hazard. So if we're talking locking down a unit, that may be inevitable because of the frailty of the particular individual. But short of that, I think there are a lot of things you can do. You can locate the doors that are locked someplace where a patient isn't always, or resident isn't always looking at that door. So there are things you can do to mitigate the impact of some of these gestures you have to make.
Thank you. We've got another question here from Catherine, and she asks, how would you suggest infusing theory into applied research and writing it in a way that resonates with appropriate audiences?
Infusing theory into applied. So I'm going to have to interpret this question. I think we are infusing applied research into theory. So I would look at it slightly differently. So if we have a theory, let's take Ulrich's theory of sustainable design that focuses a lot on positive distraction. So if we have a theory that says that social interaction, views of nature, art that relates to nature, that those three things might have a positive outcome, then they have direct application and they fall within this overall notion of a therapeutic environment. When we're talking about resonating with appropriate audiences, I did notice when I first did my research on the children's facility, one of my questions to the staff was, do you think the physical environment influences the outcomes of the children's facility? And as I recall, more than half said they did not think it had an impact. But again, that is a topic, that is an approach I think that has changed over time, because all the research I've done subsequent to that, people seem to feel that it plays some role. So I think the appropriate audience, if we're talking money, we might be able to provide information for the administration. These windows, this therapeutic environment, by the way, is not just for the patients. It's for the staff who work there and trying to reduce their stress levels and trying to, using the environment as a tool to be a calming influence. So if that's the environment, if that's the audience you're talking about, I think there's ways to tailor our response to deal with that. I'm sorry, I skirted around that because you and I can't interact directly for me to explore exactly what you were looking for.
Well, we've got another one here from Susan, who asked one for me, actually, or maybe both of us, but since it's about the Veterans Administration, I assume that I might take the lead on this one. And she asks, is the Veterans Administration conducting any research on design requirements for veterans, especially those returning from war zones? What I can tell you is we've got a facility up at White River Junction, and Dr. Peter Mills up there has developed our own internally used mental health environment of care design checklist, which is applied regularly in our facilities. And Peter has published, and I think some of his papers are referenced in Mardell's research paper. Peter has published a reduction in harms to veterans in facilities using that application. So there is some data out there and continuing research in that area. Mardell, anything you could add to that one?
No, I know that we've had recent interest from people in the VA to come participate in our PhD program here. So I think that they are working on that. Plus, the whole military health establishment has really been very core to the evidence-based design movement. So I see that as an inevitable development.
Thank you. We've got another one here from Peter. And he says as follows, you talk about projects in progress as, quote, living laboratories, end quote, for testing best practice design strategies and guidelines. How would you approach developing a research project in this context?
Well, one of the first things I do is you really need a pre and post condition. So if people are generating, or they're creating new projects, they should be gathering data from the old projects. So when let's say you develop 3 goals that you're trying to achieve, maybe one is reduced aggression. Let's pretend that's the case. So we gather data on the existing facility on aggression, and then you're going to gather it later on when you complete your facility. So that way you can, sometimes people do post-occupants evaluation without being able to make that comparison, and I can never tell whether, well, maybe they got a B+ now, that's good, but maybe they had an A- before because they don't have any ability to look back on that. So if someone has a project underway now, this is the perfect time to gather that data. I would just say one thing. People worry about doing your own research in-house, and they worry about it being subjective. So the way you get around that is you set your hypotheses out from the very beginning, and you are honorable in that you stick to that hypothesis. And the hypothesis is exactly the same thing as a design goal. So if your hypothesis is this new facility will reduce aggression, that's what you're going to be looking at pre and post. If you say staff will interact more frequently, you're hoping that staff interact more frequently with the residents, then that becomes your hypothesis. And just narrow it down to no more than, if you just focus on one thing, you'll be doing you make a great contribution, not just to your own practice. But if you're willing to put it out there at conferences or even write about it, then you're going to be instrumental in terms of getting this train going down the track.
And to that, I would add to Peter or anyone else who's considering doing research and using a living laboratory, if you're thinking about that, be sure to engage your local investigational review board, your IRB. Probably their input is not necessary, but it's better to have reached out to them and find that you don't need it than to have needed it and miss the opportunity for their input. So always remember to talk to the IRB whenever human subject research is involved.
Yeah, let me build on that, because that is an ethical requirement. And most architecture firms don't have their own IRB group typically. I don't know anyone that does. But often when you go to these various facilities, they will have their own IRB group. And the IRB Institutional Review Board, they review the research to make sure you are doing no harm to your subjects. And in some ways it protects you as well. I won't have a chance to get into that. But its primary purpose is to protect the subjects. If they don't have one, and you don't have one in your organization, as an academic, I have to get approval from my university and from the place where I'm doing my research. If you don't have one in other location, they're actually independent organizations who will evaluate your research and let you know if there are any red flags that are involved. So I'm glad you brought that up.
And we've got another question here from Mike. Michael Schroeder actually has asked, has KP provided access to its research on environmental design? And I do not know the answer to that. Mardell, KP, I'm assuming that's Kaiser Permanente?
Right. They have provided venues for conducting research, but in terms of their own in-house programs, when I did my search in behavioral health, I did not see a work specifically published by Kaiser, although they may have representatives who are publishing just under their last name, and I'm not aware of it.
I think if there are questions that we've not been able to answer, you could probably reach both of us through your contacts at the center. And that was our last typed-in question. So at this point, I should probably give you one final reminder that if you'd like to earn continuing education credits for this session, download the form found in the media library. For credit from the AIA, you need to purchase a CEU management fee, complete the CEU verification form and quiz, and email it to Shannon. Our next EDV Journal Club will be on April 23rd at 1 p.m. Eastern Standard Time. Michael Compton and Peter Sharp will have a discussion with Dr. Craig Zimmering and Megan Denham on the role of facility design in preventing healthcare-associated infection. So this event has been brought to you by the Center for Health Design's Research Coalition and the EDAC program, Evidence-Based Design Accreditation and Certification. And special thanks to the HERD Journal for providing free access to the articles we typically review. If you've not already done so, we recommend subscribing to HERD. Your feedback is important to us. Please take a moment to complete a quick survey at the link at the bottom of this slide. And this concludes our event for today. Thank you again for joining us, and have a great day.